presenting the surgical strategy and clinical outcomes of laminectomy with dural excision in dural ossification in cases of ossification of ligamentum flavum in thoracic myelopathy. So usually when there is a ossification of ligamentum flavum in thoracic spine, the usual treatment is decompression with or without fixation. But in case of when dura is ossified, then risk of the spinal cord injury, chances of inadequate decompression, then recurrence of the ossification, and during surgery CSF leak, these chances are increases. So purpose of our study is to describe our surgical technique for excision of this dural ossification. So we treated 102 patients from January 2011 to May 2019. Out of them, 28 patients we found intraoperative dural ossification. The main symptoms were numbness, paraparesis, gait disturbance, back pain, and bladder bowel dysfunctions. For all of them, CT scan, MRI, and plain radiographs were done. And we followed them, minimum follow-up of 18 months was there. And we clinically, we've evaluated them with modified Japanese Orthopaedic Association score. So in our surgical technique, we mainly used two tools, which are high-speed burr and ultrasonic bone scalpel. With high-speed burr, we thinned out the laminae and ossified dura, and then we removed it with 15 number knife blade. And ultrasonic bone scalpel was used to smoothen the edges to save the time. And fixation was done in selected cases. So when this excision of dural ossification was done, then all 28 patients resulted in the dural defect with CSF leak. We not attempted the primary closure of this dural defect because of the irregularity and size of the defect. We used Duragen patches over that defects, and meticulous closure of the muscles, deep fascia and skin was done. And for all patients, gravity dependent without negative suction, drain was kept, which was removed according to the collection of the drain from 3rd to 5th postoperative day. And we started mobilization from 2nd to 3rd day. So there were 72 ossified segments in 28 patients, in which we found maximum ossified segments or dural ossification in lower thoracic spine, which is consistent with the most of the literature. That is because of the more stress on the lower thoracic spine. And we found excellent outcomes in 32% of the patients, good in 60%, and fair in 7% of the patients. We faced recurrence at the same level in only one patient, and we had not found any neurological worsening post-op. So this is one of the case in which patient was diagnosed with multiple level lumbar canal stenosis and D9, D11. He had a very severe stenosis, for which we did fixation from D8 to D5 with good decompression. Another case in which patient was diagnosed with D6 to D11 stenosis, we did plain decompression. Another case who had a recurrence after 2 years at the same level of D10 to D11, previously was operated for C3 to C6 decompression and lateral mass fixation with D7, D8 and D10, D11 decompression. When we reviewed the literature, we found that only 3 studies are there in which they studied this dural ossification, but all of them have not found any difference in neurological recovery, even though you remove the whole dural ossification or whether you not remove it. Only main complication was CSF leak, which you need to manage. In first study, they repaired it. In second study, they left it without anything, not repaired, not kept any dural patches also. And in third study, they also repaired it. And there are different signs which are given to evaluate whether dural ossification is there or not in preoperative MRI or CT. But absence of these signs does not rule out the dural ossification that we found. So conclusion is complete removal is important. Ultrasonic bone scalpel and high-speed burr makes the difference. And preoperative counseling of the patients about the recurrence should be done. So limitation of our study was we not did for all the patients MRI and CT to see the cord expansion and complete removal of the dural ossification. Thank you.